Hello, this is Dr. Scott Worden, the TOS guy from beautiful downtown Sunnyvale, California. It's a beautiful late summer day here, and I hope all of you are doing well. Today's topic is 5 questions that we get asked by patients recently. Let's start with the first one. I hear your speakers mention the brachial plexus frequently. What exactly is the brachial plexus, and why is it important for TOS? So the brachial plexus is a cluster of nerves that comes out from the neck and goes mostly to the shoulder and the upper extremity. Now, we call this complex a plexus. There are several plexuses in the body. The brachial plexus is the second largest plexus, and that's because it's controlling a lot of very important muscles. The hands and the fingers use up a lot of brain power to manage all the things that we do as humans that other animals don't do. So if we start with the spinal cord that's contained in the spinal canal, which is the bony structure of the spine, the spinal cord gives off nerve roots at regular intervals. And we number those based on whether they arise from the cervical portion or the thoracic portion or the lumbar portion or the sacral portion of the spinal cord. Now, once these nerves arise from the spinal cord, in the case of the brachial plexus, it's C5 through C8 as well as T1, that's 5 nerve roots. They all come out through an independent side bony hole in the spine. They join together and they split up in various ways. It's a very complex network, sort of like a spider web. And from that network come nerves to the muscles and nerves to the autonomic nervous system, which controls blood pressure and heart rate and sweating. And sensory nerves come back through the brachial plexus from the fingers, the arms, the skin, judging whether your body is hot or cold, whether there's pain or pressure or a pinprick. So it's a very complex wiring system that looks like a spider web. Now, why is it important in TOS? Well, many doctors will order an MRI of the brachial plexus, and the brachial plexus by itself, in many cases, looks normal. That doesn't mean it's normal on the level of the individual nerve fiber, but it can look normal on imaging. But the problem is that TOS is not a problem, an intrinsic problem of the brachial plexus. Brachial plexus can have its own diseases like plexopathy and viral disease and radiation-induced disease. But thoracic outlet syndrome is very specifically a disease that causes symptoms when it compresses or stretches the brachial plexus. And since this is a complex spider web, and since it's different in every patient, different forms of compression or tension can cause different symptoms in every patient. Usually, though, they start out as sensory and intermittent symptoms, because you don't always hold your arm or your shoulder or your neck in a position where the brachial plexus is stretched or compressed. You may do it for work. You may have your arms overhead while you're painting a ceiling. But once you put your arms down, the pressure and the tension on the brachial plexus goes away. So there's a complex spider web of nerves called the brachial plexus, and thoracic outlet syndrome is any disease that causes compression or tension on the brachial plexus, resulting in symptoms. Question number 2, what services does Dr. Worden offer to help with TOS? So most of you who know me at all and know our Vanguard specialty imaging knows that we do the NeoVista MRI, MRA, MRV, very specialized imaging study for patients with thoracic outlet syndrome. We also in the past have done selective injections, although we don't do those at present. We also do consultations. For a lot of people who work with docs that may not know TOS well, we provide a consultation service to help them figure out whether they should go down a certain pathway towards the diagnosis of thoracic outlet syndrome. We can review prior studies as well. If you've had prior studies, we have a service to review those. But we certainly prefer the technique that we use. The NeoVista MRI has multiple patents, and we believe it's the best, the most refined, the most accurate test to help confirm that diagnosis of thoracic outlet syndrome. But remember, we do consultations on your clinical history and the doctor's reports you've already had, and we do review outside images if that will be pertinent to your care. Reach out to us, go to the tosmri.com webpage, and you'll see a big contact us button to the right. We're happy to chat with you at no charge. Can you describe how X-ray, CT, ultrasound, and MRI are used for TOS? So understanding the disease process of TOS is important to understanding how we use these various imaging tests. In most cases, in my experience, and that's a lot of experience, TOS is a soft tissue abnormality. Okay, to start with, many patients can have variant anatomy, an extra muscle, or scalene muscles that don't split properly, or an anatomic variant course of the brachial plexus through or anterior to the anterior scalene rather than behind it through the scalene triangle. So many patients are born with soft tissue abnormalities. On top of that, when you use your arms, what we call dynamic changes, then you can narrow the space between different anatomic structures, most commonly between the collarbone and the first rib when you move your arms in front of you or to the sides or overhead. So we also have to look at the dynamic changes and how bones can narrow some of these tunnels that the brachial plexus has to pass through. And then we also perform images of the veins and the arteries. Some patients can have asymptomatic compression of the arteries or of the veins, but some patients can get enough compression of the veins that the arm or the head and neck don't drain properly back towards the heart and the chest. And this kind of venous congestion can cause signs and symptoms on its own, leading up to eventually a blood clot formation, what we've seen called Effort thrombosis or Paget-Schroeder syndrome. Now, that's with a blood clot, but there are also lesser diseases such as McCleary syndrome, where patients get symptoms because of compression of the veins, even without a blood clot. So what we're looking at when we do a NeoVista MRI is all the soft tissues, the different positions of the arms and the bones of the collarbone and the first rib when you move your arms, as well as separate pictures of the nerves and the arteries and the veins. Now, X-rays don't see the soft tissues very well, and they only see things in 2 dimensions. So as a radiologist, you can interpret a lot from an X-ray, but you can't see the relationship of things in that 3rd dimension, and you can't see soft tissues very well, given the fact that a lot of TOS is caused by abnormal soft tissues or anatomic variations. X-rays are not very helpful. On top of that, for many years, some specialists have used X-rays to look for a cervical rib. That's an extra rib at the bottom of the cervical spine, or C7, above the normal first rib. And a cervical rib can take up space that's important. But in many cases, a cervical rib is more associated with arterial TOS, and arterial TOS is really rather quite rare, maybe 1 to 2% of all cases of TOS. Venous TOS is still pretty uncommon, maybe 5%, and somewhere 95 to 98% of cases of TOS are neurogenic type, and that's the type that's really difficult to diagnose. So, can you do an ultrasound? Well, ultrasound is great for looking at the blood flow in the veins and the arteries. It's good for looking at soft tissues, but it doesn't really help distinguish between the nerves and the muscles as well as MRI. And ultrasound is limited by lung and by bones. So you can't see through the bones and you can't see through the lung. So ultrasound's great at finding any anatomic plane you want, but that would require a sonographer who really knows the anatomy and the disease, and that's unusual. It's very complex anatomy. And ultrasound does show changes in the arteries or the veins when you move your arms. So it's a good adjunct test in many ways. But since the vascular forms of TOS, that is arterial and venous TOS, are pretty unusual, and the most common type is neurogenic TOS, ultrasound has less of a role. And now finally, ultrasound can be used to quite good effect to guide selective injections. Some doctors will do injections of steroids or Botox or adipose tissue or stem cells or platelets into various spaces around the body. And we're starting to do some more of that now around the brachial plexus and in the scalene muscles. For that purpose, ultrasound is great at guiding a needle into the right spot, and ultrasound does not use any radiation. Now, X-rays use a small amount of radiation, no big deal. But the final category, CAT scans, they do use a lot of radiation, and they should be used judiciously. CAT scans show the bones in great detail in all 3 dimensions. Very helpful. They can show blood vessels very well because you inject a dye into the blood vessel, let's say the artery, and you use the CAT scan to look at it, and it shows superb detail of the arteries. and of the veins, depending on the technique you choose. In most cases, the doctor has to direct the CT technologist to use different techniques to see the veins best or the arteries best. There are ways to get to see both arteries and veins on a CT angiogram, which means CT pictures with dye injected into blood vessels. But CT falls short in looking at the soft tissues. MRI is much better for that purpose. And of course, CT uses radiation, while MRI does not. Now, for changes in position of the arms, CT is just as good as MRI, and you see bones in better detail. Some doctors prefer CT because the bones are so crystal clear, whereas on MRI, it's harder to see the bones, and you have to be a good radiologist to see them. Nonetheless, MRI, in my opinion, provides much more overall information about soft tissues, which are more important in TOS. So that covers 4 different types of imaging. The fourth question is very interesting that we've been asked. What 3 medical advances do you think would help TOS patients the most? So number 1, I think we don't have a standardized diagnosis of neurogenic TOS. There are many variant forms of the anatomy and many variations of the dynamic changes that occur when you move your arms. And I think that the tests we have been shown, for example, clinical tests like Roux test or the Wright test or Adson's test. Some of these, like Adson's test, rely mostly on changes in blood flow. And there are many, many patients with neurogenic TOS who have no alteration of blood flow. So Adson's test, as good as it was in the 1920s, is really of little use today, but many doctors still associate that as one of the primary tests for neurogenic TOS. However, tests like Adson's and the Wright test and Roux test, they've been shown to be very poor, either low sensitivity or low specificity when you look at patients with neurogenic TOS. So these clinical provocative tests where your doctor moves your arm into various positions, asks you to take your breath, turn your neck, like Adson's, like Roux test, they're not that great. And even if they are positive, they don't show anything about the underlying anatomy. Keep in mind, we know from 200 years of surgical studies and dissection studies that patients are very different from one another in their anatomy. There are many variations in the brachial plexus and the muscles and the fibrous bands and even the shape of the ribs in patients with TOS. And in patients without TOS, just normal humans have anatomic variation where the neck and the chest all meet together. So imaging tests are critical for that, and I'd like to see that standardized. Along the course of that, the second thing I think we might add would be better correlation between surgical findings and diagnostic tests. I haven't mentioned EMG before, or nerve conduction velocity. These are called electrophysiologic studies, and they used to be used a lot. One person actually used them to create a category of disputed TOS because the electrophysiologic studies were negative. And that's crazy because electrophysiologic tests are negative in most patients with TOS. However, they are positive in some patients. And during surgery, rarely, some researchers have actually looked at the nerves of the brachial plexus in surgery where they can get much closer rather than down the arm where the whole signal is diluted. And they have found abnormalities of those nerves right at the brachial plexus, right where they pass over a fibrous band, for example. So I think there is value in correlating surgical findings with diagnostic tests like electrophysiologic tests and MRI. Now, MRI has been shown in the literature to be very accurate in showing the thoracic outlet, but surgical correlation would be a step beyond that and would be very useful. That means patients have to have a protocol where they get MRI imaging and maybe electrophysiologic studies before surgery, and then the surgeon and radiologist discuss the findings that are found at surgery to correlate. And then third, I think that for patients who fail surgery or have recurrent symptoms, it would be great to have postoperative imaging. I do see a few of these cases that come to me because the patients are in a lot of pain, or the patient sees a new doctor and the doctor says, the surgery doesn't seem to have helped. Can you image and show me what's going on? And we have found some surprising things. So many of the surgeons who perform this kind of surgery don't get imaging before the test, and they're unlikely to get imaging after the surgery. So 3 things that I think could help patients. Number 1, standardized diagnosis. Number 2, surgical correlation with diagnostic tests to understand how well they work. And number three, more postoperative imaging to understand why some patients fail or recur. Now, final question we have for today's talk. What are the three most important things I can do as a TOS patient to help myself? Well, the first thing is the same thing we always say here, and a lot of our guests say, you have to advocate for yourself. Many patients we speak to come to us having been told that they can't have TOS. Either it doesn't exist or it doesn't look like they have it on a couple of quick tests like an ADSENS test. But in fact, there's enough to read on Google. Our website, tosmri.com, has lots of educational stuff, and there are other websites that if you as a patient believe you have TOS, it kind of falls on your shoulder to find the right kind of doctor and the right kind of tests. We can help with that if you contact us. We're glad to refer you to people we know who do adequate and better than adequate, excellent TOS evaluation. But don't let a single doctor tell you it can't be TOS because TOS is disputed or you don't have it and they don't even do provocative testing by moving your arms and your neck. So number one, advocate for yourself. Use all the resources we have on the web and use people like us to help you get pointed in the right direction. Number two, you want to recognize that we still have a lot of unknowns in this field. The previous question about what three things could we do to advance TOS knowledge? Well, that shows you that there's lots of things we still don't know. And the people like me and a lot of other people I work with who are excellent at asking further questions and trying to answer them are very actively involved in this. And I think you should understand that some of these questions you ask might not be answered. It doesn't mean you don't have TOS. It means we don't have a definitive answer for it. And remember, just because something isn't known, it doesn't prove that it's not there. The absence of evidence is not the evidence of absence. So again, don't let a doc talk you out of it because no one has yet confirmed your diagnosis. And the third thing I would say is use the web as we talked about, but use those parts of the web like social media wisely. There are many people out there with opinions. We see it all the time about sports and politics, unfortunately, and about TOS. Because we have unanswered questions, we find people who say, oh, I'll fill in the blanks, and they throw an opinion in there. But remember, as doctors and scientists, we have to have peer-reviewed papers. We have to have papers that other people look at and poke holes at, right, until we're pretty sure that it's a solid theory and it becomes fact in that way. All right. So what are the three things you can do as a patient? Advocate for yourself. Don't let a single doc talk you out of this. Number two, remember that there's still unknowns in the field, although we have good people who recognize a lot of this. Some questions can't be answered, and don't let anybody else fill in those holes yet. And number three, use social media wisely. Let it point you to experts, but those are not the experts who run social media boards. And with that, I'm going to pause and we're going to take questions about TOS. All right. Yeshua saved me. What is the success rate for a properly performed severe neurogenic TOS decompression? Now, I can't really limit it to severe neurogenic TOS. From the literature that's out there, and there are many papers published on surgical success rates, I can tell you the numbers, but they don't split it up very well into mild and moderate and severe, and we don't even have real categories for that. But in general, of the patients who go to a surgical decompression, a first rib resection through various approaches, the approaches all tend to have the same results. About 85% of patients feel good or great after the surgery. But by 2 years, it's only about 70% who feel good or great or completely resolved. So there's a drop off over time. First of all, the initial surgery is good for 85%. That's a 15% failure rate. And we really would like to know why. Did they have neurogenic TOS? Was the anatomic problem underneath actually addressed and corrected? And then we also have a drop off over 2 years that patients get recurrent symptoms. This may be due to scarring or fibrosis around the brachial plexus, but there's still a lot to be known about that. So 85% after surgery are doing well, and 70% at 2 years are doing well. And I can't split it up into mild, moderate, or severe because we just don't have that in the literature. Thank you for the question. The Bay Area Backyards B, is that what I saw? All right. Post-surgery 4 times, bilateral rib, first and second, anterior, middle scalenes as well. to additional surgeries, dismantling my intercostal breathing muscles and pectoralis minor. I'm curious to see what this channel and conversation is about. I'm glad you're here. Thank you. If I can help you all have a better, can we go back one? If I can help you all have a better understanding from a patient's perspective, please feel free to ask questions. Good. I am a trained ultrasound technologist from Kaiser since 2011. I teach ultrasound case study review to my graduates, and basically, I have knowledge in the medical industry. Dr. Wharton, your name is so familiar. That's good. Without Googling you, I'm assuming you're in the Bay Area. I could be wrong. All right, so Google away. I am in the Bay Area, but we work around the country because we have imaging partners. So the first thing is, I have to tell you, I can't offer individual medical advice through this channel. We're happy if you reach out to us through the contact us on our webpage, tosmri.com. Contact us. We're glad to set up a consult if that's what you want. And this is going to be a pretty detailed case because of so many procedures. So I'm going to guess at what your main question is and your offer. We're always glad to have discussions with patients who contribute, because without having gone through it myself, I can only share those stories, but I didn't experience them. To have so many surgeries suggests to me that perhaps the diagnosis wasn't clearly made in the beginning, or without imaging, maybe they didn't know what was the underlying cause, because there are many causes of TOS. And if they weren't properly addressed after surgery, sometimes scar tissue can form, which can make symptoms worse. So I don't want to go into that in any detail for your privacy reasons, but we can discuss it ourselves. So let's talk a little bit about why surgery can fail sometimes. Also, the fact that you brought up the pectoralis minor syndrome. Surgery, first of all, is based on some of these clinical tests that we know are not accurate. Secondly, many surgeons will do the same procedure every time. That's good for some reasons. But if we know that what they're operating on, the thoracic outlet, has many anatomic variations, well, then you have to ask yourself, surgeon, if you don't know what the anatomy is going in, are you just kind of taking a flashlight and putting on a helmet and walking into a cave and figuring it out as you go? I mean, we use imaging for almost every diagnosis in medicine that I can think of that requires surgery. There is no magical tissue or magical change in your structure that cannot be seen by imaging, but can be seen by surgeons. If a surgeon can see it, and a surgeon is going to fix things by anatomic alteration, then it has to be seeable by imaging. Maybe the technique for imaging isn't perfect. Doesn't need to be, because the current diagnostic tests are far from perfect. So my little bugaboo in my soapbox is we need more imaging, especially MRI, which is harmless. There's no radiation, and it shows a lot about what's going on. Combined with the fact that different patients have different anatomy and different causes of their TOS, we should know when we go in, what's the thing we really need to aim for, and what are the other things that we can leave alone. In many other parts of surgery, surgeons aim for minimal surgery. They don't go in and do a big open gallbladder removal nearly as often now, because we have tools that allow us to just remove the gallbladder without disturbing the bowel and without disturbing the liver. So all surgeons have aimed towards more effective, targeted, minimalized procedures, but it just seems in TOS not as many people are doing that. So that may be one of the reasons for a surgical failure. Also, there may be a misunderstanding of TOS. We include the pectoralis minor syndrome, and all the literature out there talks about pectoralis minor syndrome being caused by compression of the brachial plexus behind the pectoralis minor muscle. Now, if you look at the anatomy and you look what happens when you raise your arms, it's very, very unusual to get compression of the brachial plexus in that space. Now, why do people persist with this idea, though, that they need to remove the pectoralis minor muscle because there's compression of the brachial plexus, which just doesn't happen? Well, since 1950, when a guy named Jerry Lord did the first recorded pec minor tenotomy that I can find, and there may have been some earlier cases over in Scandinavia, but I haven't found them yet. So when he did that and the patient had improvement, you could assume that it's because this muscle was compressing the brachial plexus. But he didn't have imaging like we have now, and the imaging papers, the articles out there, show that it's unlikely to get compression there. In fact, patients without symptoms get more narrowing of that space than patients with neurogenic TOS get. And I can tell you from my experience doing many, 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 many studies, it's very rare to see compression there. But if you release that tendon of the pec minor, it allows the shoulder blade to move in a new direction. And that may be the secret to this whole thing. We need more research on it, but I believe in using the literature and the facts as they are. So another reason for surgical failure might be that maybe you had pec minor syndrome, but your doc originally did a first rib resection, or maybe you didn't have pec minor syndrome and your doc did the pec minor tenotomy, and that allowed the shoulder blade to move, and now that's making things worse. Those are the sort of things that would come to mind. All right, so that was kind of a lengthy explanation for a good question, and I thank you for contributing. And I hope we'll see you again. RGV956 asks, having a strong support system is so important. My daughter has TOS, and it's a daily struggle to keep the right mindset. I wish there was a magic pill to make her symptoms vanish. Wow. Well, I think we all feel for any parent who has a child who's sick, and TOS is just a chronic, nagging problem. If you haven't seen us or discussed with us before, please reach out and we'll do our best to help you. I have kids too, and I have friends who have kids who have TOS. Mine do not, fortunately. And it is a challenge, but it's another reason to do everything we can, like good imaging and working between a radiologist and a surgeon and a pain management doc and a sports medicine doc to work with the whole team to come to the best conclusion. I don't know if your daughter's had surgery or if she's considering surgery or if somebody's recommending surgery, but that's an important decision to make. And I think that that's something you want to get more than one doctor involved in. Each of us specialists, unfortunately, have our own little field, but many of my colleagues, we do reach out together and try to share what we know to expand what each of us knows and get more common sense. So again, I make the offer, reach out to us through tosmri.com and we'll see if we can help. And thank you for piping in and sharing. PMFG says, what is the typical recovery time required after TOS surgery? And thank you for the webinar. Well, thank you for attending and thank you for sharing a question with us. I'm not a surgeon, so I'm going to just say it's like one of those Holiday Inn Express commercials. Take what I say with a grain of salt. Many patients will feel significant changes right after surgery, but they do have pain locally because surgery it disrupts tissues. But many patients will still, despite the background pain from the surgery, recognize that some of their neurogenic symptoms are significantly improved. And many patients will improve over the first couple of weeks to 6 months after surgery. Now, I don't know the endpoint. Some patients, from what I've read, will continue improving out to a year. We have a few patients we've followed with, and then beyond a year, they keep getting improvements, although the majority of improvement would be in the first 6 to 12 months, from my understanding. It also depends on what were the symptoms you had and what were the causes of it. So we've had some athletes who, one interesting story is a young man who was a really good left-handed baseball pitcher, could really throw a fastball in the mid 90s and had TOS, and went through the process of diagnosing and clearly had TOS, and he underwent surgery with a very experienced surgeon. And several months later, I was speaking with his dad. His dad related the story that they were playing soft toss and son was feeling better and starting to throw more. And his son just volunteered one day, I can feel my fingertips. I didn't realize I haven't felt my fingertips in 10 years. That kind of story is, first of all, very encouraging. We like to see people get better, especially young, healthy people. And it also reminds us that there's a lot of complexity to this. And because it's gradual and subtle in many cases, patients don't even know what symptoms they have until they're gone. So thank you for the question. It's just me. All right. Can TOS be caused from having scoliosis and ankylosing spondylitis? So there's not a lot of literature on this. However, scoliosis, where the spine is curved, can occur in different parts of the spine. If it occurs in an area that changes the positioning of the neck and the upper thoracic spine, then I'd say yes, it could potentially increase the risk of getting TOS, because TOS is very motion dependent. It depends on the position of the shoulders relative to the chest wall. It depends on the strength of the muscles and the balance of the muscles, keeping the shoulder blade and therefore the collarbone in safe positions. So if your chest is tilted to one side, one rib will be tilted higher than the other and would be more likely to find narrowing between that rib and the overlying collarbone. Yes, I believe scoliosis can increase the risk for TOS, but not enough literature out there. Number two, ankylosing spondylitis is where the joints of the sacrum, the lowest part of the spine, can get fused to the pelvis. And you can also have ossification or bone formation along the spine that stiffens the spine and can change the shape of the spine. I have not personally seen a case of a patient with ankylosing spondylitis who also has TOS. That may be partly due to the fact that ankylosing spondylitis is slow and progressive, and TOS patients tend to be younger. So it might be that some patients get older, and as their ankylosing spondylitis worsens, their posture and their body shape worsens, and that may predispose to TOS, but I just haven't seen it yet. So I don't know any literature either of putting those two together. If it's out there, it's going to be minimal. All right. Thank you for the question. It's a good question. Charisse Senkel. Dear Dr. Werden, I love questions that start out that way. Thank you. I'm a medical doctor from Germany and doing a research project about TOS in surfers. Very interesting. I am collecting surfer cases worldwide. Do you ever treat surfer patients in your practice? Thank you. Great. Thank you for the question. I really appreciate that. I'm glad you're doing research. We actually, in Northern California, the water's pretty cold, so we have some surfers, but it's not like those pictures you see of the Beach Boys and everybody surfing in Southern California. So even in Southern California, I don't get a lot of that in the history. So no, I haven't seen a trend of that. I don't remember seeing surfing as a primary athletic activity in patients with TOS. However, if you have some interesting findings, you want to reach out, I'm more than happy to discuss with you, because I might learn something new and it would be very interesting to figure out what the causation is. Thank you for a very interesting question. That's cool. Maybe you have colleagues or no practitioners that treat surfers. It would be very helpful to connect to them. Well, I'm happy to connect any of my colleagues with you. I will ask around. I haven't heard it from my docs, but I'll bet you I'll get a few laughs from that, because some of the docs are places like Las Vegas. I don't know how many surfers they see there. And New York, where, again, they probably don't see many surfers there, but we do have people in Atlanta and in Florida. So maybe reach out. We can keep in touch. I'm glad to discuss with you and with my colleagues. Thank you. All right. Well, I'm going to say that that's the last question. All right. I want to thank you all for attending, especially the new folks who are here. I want to encourage all of you that at Vanguard Specialty Imaging, I and the team are happy to try to help anybody and point them in the right direction, even if we don't provide our services. We provide elementary things like connecting you with docs for no charge. We do consultations in depth if you have medical history and you want to know more about you or a daughter or son. We can provide imaging review if it gets to that point. And of course, we do our NeoVista MRI, which we believe is a great test for helping docs confirm the diagnosis and understand what different treatments might be. So please reach out to our website. Oh, Chris Sharis, Dr. Senkel. Yes, just go to our webpage, tosmri.com. At the header on the top, just look to the right, and there should be a nice button that says Contact Us, and there's a form to fill out. And then my team will put me in touch with you, and I'll be absolutely happy to speak with you. Same for other patients here. We do as much as we can to help, while my team tries to protect my time so I can do the heavy lifting and think of all these questions. We are always happy to speak to people and to help people out. And for now, I'm going to check out and say I'm Dr. Scott Worden, the TOS guy. I hope you're all doing great. Thank you for attending, and we'll see you for our next live stream.